Okay, it looks like it's 9 o'clock, so I'll probably get started. First of all, thank you all for joining me this morning. Although this is an incredibly kind of, in my opinion, awkward platform, I really admire the folks from SEO and UPDO for creating this platform and the University of Kentucky for organizing it all. It's important that we continue our education strategies as we this pandemic. All of you are well and safe. Please don't hesitate to stop me and ask questions. Today I'm going to be addressing kind of what I call masqueraders of sinusitis. So we all know that sinus symptoms can be in other diseases, and the cases that I'm going to present in just a moment all sort of highlight similar presentations, but very, very different etiologies. And so I want to keep in mind that not every like a duck looks like a duck is a duck. This is not to say you should be looking for zebras for every condition, but it's just to put your thinking hats on, think critically, and when you see a patient, find elements of your physical exam and your history to that diagnosis. You don't want to be mistreating folks and misdiagnosing folks. So without further ado, this is the first time that I've used Prezi for a Zoom meeting. So if there's any connectivity issues, just please let me know, Sarah, if it's not coming across well. So I just want to review sinus symptoms: nasal obstruction, rhinorrhea, facial pain and pressure, and hypnosmia or anosmia. Classic symptoms, but not always reported in every chronic rhinosinusitis. Nasal obstruction, most commonly occurring in about 83% of patients, and the second most common is actually facial pain and pressure, which is not a very specific symptom. And so it's why these sort of symptoms and their cross contamination, so to speak, other diseases such as allergy, migraine, autoimmune diseases, and malignancies, we need to consider all the factors, and we need to utilize other tools in our toolbox. So that otolaryngologist, that's our nasal endoscopy and our CT scan. So extremely crucial. So I'm going to start us off with a case. I had a African male who presented to my office with classic sort of sinus symptoms. Had headaches, and I always really harp on my residents, you need to clarify what congestion is. Congestion can be, to the patient, be facial pain. To me, I want to clarify if they have nasal obstruction, or if it's that pressure feeling, because that's going to determine, kind of get me on the way for a diagnosis. He also had thick rhinorrhea, and this was going on for a long time. He had been tried on multiple antibiotics, tried some nasal irrigations, and really had some other symptoms that kind of pointed to CRS. So his smell diminished as well. He also had some epistaxis, and that was unilateral. So you're kind of thinking, okay, why is it only on one side? And really, from a social standpoint, it's important to note things like his smoking status, and then for a living sort of environmental exposure. So again, in a normal setting, I'd probably, first of all, be walking around the room. This is a little weird sitting down. Also ask you guys to kind of tell me what you would do next, but not possibly viable in this situation. So I'll just move right along. So the next thing you do with this gentleman's in your office, you use the tools that are available to you. So you do the nasal endoscopy. And this is what you see. So again, this is edematous mucosa and then pharynx pus. Due diligence, you take a culture and you're going to start him on culture-directed antibiotics. And As you're getting that started, you're thinking to yourself, okay, so I really want to see how bad this is. The other side looks pretty good. In the unilateral disease, you want to be thinking, you know, things, more severe things, tumors need to be on your differential. So you probably want to get some imaging. And again, you can do that, do a post-treatment scan to assess that. So next I'll do his imaging, and we'll go from there. So this, I think this really sheds a lot of light as to what's going on with this gentleman. Let's see, get that started. Come on, technology. There we go. And I slow it down here a little bit. Start playing that again. That's what I was worried about. Okay. Guess I just have to be patient. Okay, as you scroll through this, you notice mastoids look good, sphenoid, a little bit of thickening, some osteoneogenesis, and then as I go back, kind of roll back if this will let me. You'll see that there was some very gnarly looking teeth right about here in positive arrow signs. So you can kind of see that definitely there's erosion of the bone and periapical abscesses on both sides. Actually, the arrow pop up on the other side too. So very good dentition, and that's consistent with your physical exam. So, so what we're dealing with here is odontogenic sinusitis. And I like to highlight this as being, you know, an obvious cause for unilateral sinus, chronic sinus disease, but it has some nuances in treating it. And so it's not your run-of-the-mill sinusitis that affects the entire nasal cavity. That's an inflammatory disease. This is marked by, so even after a surgical intervention to open the sinus and restore draining, proper draining and clearing that infection, the patient will have oftentimes osteitis, and you could see on the CT scan osteoneogenesis formation, and which really leads to a crushing and kind of a low-grade smoldering infection for a very long time after the procedure. So I'll tell folks that at the onset, listen, this could be a long course. You're going to see me back to debride multiple times. We may prolong that topical or antibiotics afterwards. The teeth need to be addressed. That's really the most of the problem. And so how you address the teeth depends on your oral surgeon that's working with the dentist. Some of them will simply say to you, gosh, if we pull that tooth in the setting of a completely obstructed sinus, that patient will have an oral enteral fistula. And if that's the case, you may be forced to address the sinus first. And oftentimes that makes a little sense to avoid fistula formation. And again, these are going to be mixed flora because they're from the dirty, dirty mouth. So addressing that's in your antibiotic post-op regimen and pre-op regimen is important. Okay. We'll move on to our next case. So this was a very pleasant 50-year-old gentleman who was HIV positive, coincidentally. He had developed kind of unilateral facial pain and swelling, and it would have been going on for over 6-8 months in duration. And then he also had this very foul-smelling, tasting drainage. And the poor gentleman worked at a perfume counter at the local department store, and really this was ability to help his clients with their purchases because he really couldn't weigh into the smell and help guide them in that direction. So it was cumbersome for him. And then he had moderate nasal congestion. It was actually bilateral and seemed to be worse at night. It seemed to be worse at night when he lay down. So he had a Kaposi sarcoma that had been removed, but he now was on heart and was for prophylaxis. He was doing well from an HIV standpoint. He could not really involving himself in his medical, and really didn't have much idea of what an 84 was, but he had been compliant with his therapy. So, and the reason it's important is because you want to know his immunologic status. Even with an immunocompromised patient, that you can see common conditions occurring to their account. And then he'd also had some dental procedure about a year ago, root canal. He had several extractions. So he's in your office again. You're going to scope him, and again, it looked very similar to the last guy. Exactly the same, in fact. But this is just to demonstrate that you did see purulence on exam, and you're going to do the right thing and get a culture and find out what you need to treat him with. He had been on a couple of courses of antibiotics. You want to establish that he doesn't have a resistant organism or an exotic organism, given his history of HIV. And more likely than not, it's just a common organism, but as he's on antivirals. And then again, how are we going to treat him? So you're gonna do him with antibiotics based on your findings. You're also going to do standard treatments for chronic and sinusitis, and you're going to recommend nasal saline irrigations, topical nasal steroids, potentially even oral steroids based on the guidelines that we have for treatment of this disease. And then you're going to want to get some imaging, because you again, it's a unilateral disease, so you want to make sure that you're not missing anything, and you're assessing the severity of the disease. And so he comes back and he still has symptoms, which this gentleman did. So post-treatment scan. One moment here. Oops. Try that again. Oh, technology. Let's see here. It's just buffering. This is really stressing out my internet, I guess. Here we go. So normal frontals, concha bullosa on the left. Yeah, wildly obstructed nasal maxillary sinus. The rest of the sinuses look really good. And you saw there's a white body in that red maxillary sinus. So the history of this one was related to the fact that he had a root canal recently, some extraction. So he had an extracted molar, the tooth root broke off and was in his maxillary sinus. So you see this from time to time, foreign bodies, particularly dental type foreign bodies. That foreign body can serve as a base for infection, and enough really act a lot like your or donogenic sinusitis. Treatment is often pretty similar. So again, culture and antibiotic treatment. Oftentimes these are also anaerobic mixed flora. So treat them appropriately based on your cultures is important. And also getting an anaerobic swab. The one was MRI, and so he was treated with Bactrim. And the next thing I kind of want to consider in addition is, how are you going to get that foreign body out? He has, if you notice on the T-scan, it was rather inferior along the floor, which you would expect in the location of the extraction. And so are you going to be able to reach that endoscopically, even with your angled instruments? And oftentimes we'll your frontal and remove with some of your curved instruments to try to get that out of there. I always like to have your backup plan where you perform a standard maxillary enterostomy and you're not able to get it out. What's your next step? Are you going to do a modified medial maxillectomy? Are you going to like swing the inferior turbinate over to access it, or are you going to do a do a Coldwell Luck to approach it? And there's multiple ways to consider doing that, but you need to plan your surgical intervention up front, and then ensure that you have talked to the patient about the options, because if you are doing a Coldwell Luck to approach it, you really want to let the patient know that they're going to have a incision under their lip, and potential complications associated with that, as opposed to just an intranasal endoscopic approach. Most of the time you can't get these out endoscopically, however, so, but keeping that in mind. And infection also complicated with likely osteitis, and so it's important to tell them, counsel them up front that they are going to have some problem. Okay, moving on to the next one. So this is another patient, very similar sinus pressure symptoms. Headaches is probably a little bit more prominent. She'd been on course of antibiotics. Keys, she's just like most of the patients that are going to walk into your office, that she had multiple rounds of antibiotics from her clinic. And then she also really struggles with right ear pain and pressure. And so she says, hey, can you also look at my ear, because it's quite painful for me. She does have that sort of red herring. She has a history of migraine that are kind of more hormonal related. Seem to have improved after she OCPs. So she already takes Flonase, Zyrtex for some mild allergy type symptoms, and those are really well controlled. So you scope her in the office, and it looks beautiful. You don't see anything. There's minimal edema, no mucopurulence, but she's off. She's incredibly symptomatic. So what is your next plan of action? In my hands, a patient like this who's incredibly symptomatic, but I don't see him on endoscopy, I want to try to get him on the right treatment path right away. And there's a couple of studies that suggest that imaging up front is helpful for sealing the diagnosis, and then getting, like I said, getting the patient on the right treatment algorithm. So I would perform imaging. So this that's what I did in this young lady. You could consider other treatments. So you could look at maximizing her allergy management if you think that's really playing the role, but particularly in a patient, or maybe migraine management if you think that it's more pain predominantly. But everything looked pretty darn normal, and so I wanted to know what was going on with this patient. So let's see. I'm gonna let that play. So we get a CT scan, and you'll see here in a moment, the sinuses actually look really good. The nasal cavity also looks pretty good. So you're not seeing kind of allergic edema or that central compartment edema. And you notice I started a little further back to respect your time, so we're not running through the sinuses. But look at this joint here. So she has pretty severe TMJ arthralgia. She's got a nice earring over here. But again, that is pretty destructive, and even may require some more aggressive management. So again, the keys to the diagnosis here is, one, a good physical exam. Examine ear patients in the office, as I'm sure you do. One is, if the otologic exam is normal, you're looking for other, and the pain is predominant, so you're looking for other things that cause ear pain. And I always palpate the temporal mandibular joint with her. When I saw her in the office, she had crepitance with articulation. And so that was cueing me in that something was going on there. The other thing was palpating the temporalis tendon, temporalis musculature, and the masseter. They tend to get a temporalis tendinitis, or and myalgia is associated with clenching, grinding, or just arthritis. And she has a pretty severe arthritis in that right jaw. So on CT scans, this is an example of someone who had been diagnosed by multiple people, but the antibiotics probably weren't really helping TMJ arthralgia. And the treatments for these were go over here, but they're conservative treatments and then more surgical treatments. So I actually, because I see a lot of this, have a TMJ handout to discuss conservative measures, including mouth guards. And we work with the oral surgeons and therapists who really enjoy doing TMJ. Not everybody enjoys doing TMJ. So if you find a provider who enjoys it, hang on to them and don't let them go. But I recommend to folks that this product, the bed bug, is helpful. It's a warm heat compress. We try non-steroidal anti-inflammatories if it's not contraindicated. And then talk to them about a night guard with their dentist. There are some over-the-counter ones that are helpful, but I find that particularly if the patient doesn't have a standard size mouth or has had any sort of dental work, that kind of challenging. So getting one from your dentist, and then warning folks that they're not always covered by insurance companies, so that they know that ahead of time, that they may have to pay out of pocket for some of that, or maybe their dental plan will cover a part of it. And then when that all that fails, and and the other key part of that is physical therapy, which can be incredibly helpful for this. Surgery may be indicated. All our oral surgeons require that they've had at least a couple of months of physical therapy prior to undergoing a surgical evaluation for this, and that they're requiring a significant amount of pain medication. These days, less so because more people are reluctant to prescribe the narcotics that they were maybe prescribing 10 years ago. But that being said, this is what the joint replacement looks like. Procedure, and if you ever get the chance to see one in their procedure. So again, that's kind of the route that we took with this young lady. Very presented kind of with sort of sinus symptoms, and patients, because of the temporalis muscle and because of the otalgia, will actually complain of sort of facial pain and pressure. And so that's important to consider in your differential for our sinus problems. So second to last case, thanks for hanging with me. The next one's going to be a 12-year-old Hispanic girl. She really has sort of a classic chronic sinus symptom, pain and pressure. You know, she says it's like behind the eyes and across the forehead, and she feels fatigue. Some of the other symptoms after questioning sort of started to bubble up to the surface, that she had this often had to lie down and the pressure got better. She had clear rhinorrhea that was bilateral, key and crucial here, not unilateral. That in general though, and she said she had congestion, but in general, she could breathe pretty well out of her nose at most times. So not nasal obstruction, and didn't have any difficulties with smell or taste. And then you start to ask her more questions about the pain and pressure. And this is where I think you really got to think about other things when pain and pressure is the prominent symptom. I screen all my patients for the IA criteria for migraine, and for lots of reasons, and we'll kind of talk about that. But I ask about things like photophobia, nausea, and this young lady did have those symptoms. Also, family history is key. If one mother, grandmother, sister have this, then she does as well. So she really didn't have any allergic symptoms. We did a scope. 12-year-old, she tolerated it quite well. Girls are usually easier than boys, and it looked perfect. So the question for a normal exam, you've got some historical clues that kind of pointing towards migraine, right? She's got the photophobia, the nausea, prostachism where she has to lay down and sleep it off. Actually, she also had a history. Mom had migraines. So all these things are pointing towards that. In this patient, how would you be jumping towards imaging? I think if you didn't have any other concerning symptoms, so, you know, it wasn't specific warning symptoms, it wasn't posture position related, she didn't have unilateral CSF, or she didn't have any nasal obstruction symptoms, you might want to consider empiric therapy right off the bat, because the historical clues are pretty strong in this case. She's meeting most criteria for migraine. So you could consider empiric therapy, and if she didn't respond, consider, either a referral to a neurologist for headache evaluation, and or kind of upping the game as far as the different therapies that you can try for migraines. Or you could proceed, if you have a patient, a very anxious mom, or a patient and a mom, or parents, excuse me, I shouldn't just throw moms under the bus here, but parents that really are concerned about it. And oftentimes these patients are coming to the rhinology office or ENT office already knowing in their heart of hearts that they have sinus disease. And that's what they've been treated for. That's what they've been told for, almost years now. So it's really ingrained in them that they have sinus disease. So sometimes you want to consider, and this is you want to consider doing imaging front, because you can really counsel your patient and get them on the right pathway to treatment if the CT scan is normal. And this is where I will spend a little bit more time with my patients, because talking to her, I've got a normal scan and I've got a history that's very suggestive of migraine. So I'm going to tell her up front that if I'm going to get a CT scan, if it's normal, and there's a chance that it's normal, that we need to look for the other causes of the symptoms that she's having. Acknowledging that, yes, she does have symptoms, because that's what people's fear is, that if the scan's normal, that you tell them that they're crazy, that they don't have symptoms. But tell them, listen, we're going to find the cause for this. And it may be something like a primary headache disorder, such as migraine. And so just, if you preface that, if you set them up for that, when you come back with the CT scan, they're going to already have that seed sort of planted, and it's a lot easier to make your case when you have that discussion up front. That's something that I'm doing in clinic. And as far as migraine and sinus headaches, we know that from several good studies, and this is one of the earliest ones in 2004, this group in the Archive of Medicine published a study looking at almost 3,000 patients, and 88% of those patients that walked into the door with a self-reported or even physician-diagnosed sinus headache actually met criteria for migraines. And so we know that the prevalence is incredibly high in the population that are diagnosed with sinus headaches. So if you're a betting person, if a patient walks into your office with sinus pain, it's probably, there's a good chance that you may be dealing with either a migraine or a primary headache disorder. And we know, I'm going to talk a little bit about why this is so complicated and why patients present to us, but it has a lot to do with the fact that they have oftentimes a preceding autonomic dysfunction. And what that means is that they will get rhinorrhea, nasal obstruction kind of inflammation that precedes the onset of their headache. And so with the nasal symptoms and a headache that follows, a lot of times that's why they're confused as sinus headaches, because they sort of correlate those as being as linked. And so that's why, and then even when folks are asking, in walk-in clinics and primary care offices, they're asking about those symptoms. Yes, they do have nasal symptoms, so it fits the picture, and it's an easy diagnosis to make at this stage. You have to, on your thinking hat, and look for symptoms. So the mechanism of migraine is very, wasn't well established, but much more clear nowadays. Initially it was thought to be related to vasospasm, but now we sort of have a better understanding that it's a primary neuronal dysfunction. And because of that, there's a sort of diffuse cortical spreading depression that occurs during a migraine. And throughout this depression, there is activation of trigeminal efferents, and that leads to that autonomic function, because the trigeminal nerve is related to several mechanisms with our autonomic nervous system, and will cause symptoms of rhinorrhea and nasal swelling, etc. And now we're starting to understand there's a couple of other key mechanisms. We know that calcitonin gene-related peptide has been implicated. It's one of the mediators for this. And so there's been interesting therapeutic targets of late that have been established. And that we know that substance P plays a role and creates probably the pain that is experienced during this migraine. It's also more interesting, more recently, we're finding the CGRP may be related in some of the reasons why people get medication overuse headache, which is very prevalent in this sort of migraine population. Non-steroidal anti-inflammatories and Tylenol, extremely accessible to the American population, so they will take to help with the headache. They get a buildup of these substances, and then when they stop taking the medication, they get a rebound, and it just becomes a vicious cycle. So again, more to come with that, but again, there's to be mounting evidence that this is playing a real role. And so that brings us to our our treatment algorithm. So, you know, there's the classic abortive measures. So you're keeping your SSRIs are still first line as a treatment and diagnostic measure. And you have to understand that you need to be used them carefully in people with cardiovascular disease. There's Remigepant, excuse me, not one I say very often, but and a couple other CGRP receptor antagonists that are out on the market that your neurologist may prescribe. And then again, NSAIDs, antiemetics, and other analgesics. Again, we're trying to avoid narcotic overprescription these days, so that's not in the treatment algorithm. And then prophylactic measures. So if they have migraines more often than somehow my screen started to, let me close this. It's good to see my mail, sorry. There we go. Okay, so again, important to know a couple of key things to do to treat these patients, so that you're not just sending them out of your, sending them out the door with nothing to do, no treatments. And you know, if you're like me, it takes a long time to get in to see neurology. So it's important that you make sure you are helping them out as best you can. And so I'll start them on treatments right away. So our last patient, this is an interesting case that came in rather recently. A young gentleman who, young gentleman, very healthy guy. I mean, runs, man's super healthy. Shows up to my office with a history of 4 episodes of sort of double vision that started in his left eye following an upper respiratory infection, or what he thought was a sinus infection. Each time it was preceded with either one of those. He was actually in Colorado last year hiking, and it, you know, he sort of felt like a cold came on, thought maybe it was more that high altitude. Since he's from Nebraska, he's a flatlander like me now. So he felt like it was maybe deconditioning or like high altitude sickness. But then he had to get double vision in that left eye. He presented to the ER there and was given antibiotics. ENT was consulted at this private hospital that he was at, and they actually offered him surgery, but then he started to get better on antibiotics 24, 48 hours prior to the scheduled surgery, and he just decided to hold off. So that's the sort of the history as he's coming into your He had another episode recently, and then he showed, started on Augmentin, but it didn't really seem like it was clearing up all that well. And he still had some double vision. Like I said, he's really healthy. So when I scoped him in the office, he did have some pretty significant mucopurulence bilaterally, but I would say worse on the left. But interesting was his ocular exam. So his orbit did not show any chemosis or proptosis. However, he had gaze restriction in the medial direction. And he'd had a CT scan from previous, and I was kind of working on those CT scans in Colorado from other in town here in Omaha that he had seen. And so I him, came back, just run-of-the-mill stress, started him on antibiotics, and he actually responded very well. But I got a CT scan to figure out what was going on to get a snapshot of time. So I'm going to show you what that showed, hopefully. Got to be at least 1 for 3 here, 5. And so, you know, his sinus scan was actually, there was quite a bit of stuff both sides. I'll just scroll through like this. So you can see right sinus disease, left thickening in the maxillary sinus, also some secretions in the left, maybe some thinning of the lamina right up adjacent to that left orbit. The medial rectus looks okay. There's no periorbital edema. There's nothing to suggest an interorbital, intraconal, or process going on. It actually looks, but he's got surrounding sinus disease. So you treat him, he gets better. And then you say, you know, we should probably have you see ophthalmologist. So while he's waiting for that, you put him on nasal steroid sprays and saline irrigations, and he has to get an ophthalmology, but it comes back a month later, double vision. This time as much with sinus symptoms, but he went to a walk-in and they gave him Augmentin again with his history. And the diplopia is actually seeming to get worse after 5 to 7 days. And so, you know, one of the questions was, do you repeat imaging? Do you get more soft tissue to see if there's something else going on? Either in, you know, I'm not thinking any cranial neuropathies, but wondering what's going on. So we get an MRI, and the MRI looks completely normal. I mean, he doesn't even have any sinus thickening at this point. So I'm starting to think that there's something else going on. The other important thing is that his symptoms, sorry, spoiler alert, his symptoms are actually just developed on the side. And he not only just had medial gaze restriction, but also some lateral gaze restriction. So I'm like, you need to get in to see ophthalmology. So they saw him very soon thereafter. And we ordered lab testing, but he eventually was diagnosed with myasthenia gravis. And this is one way that patients can present. About 50 to 85% of them actually present with ocular symptoms to start. And it's usually both sides, but they may or may not have peripheral weakness. And that really didn't stand out in this super healthy athletic guy. It was just ocular symptoms. For the folks that are diagnosed with MG, they tend to have develop peripheral weakness as well. About only 10 to 15% of them will stay with just ocular only symptoms. And his lab studies came back elevated, so it was a pretty clear diagnosis out there. Know that there may be triggers for this condition, and for him, the trigger was actually illness and stress. So he was kind of stressed out about this probably the second time, which is what triggered that. His sinus disease is likely a trigger for this to worsen for him. Also know prednisone can worsen his symptoms. So he had been placed on prednisone as well as the Augmentin on the walk clinic, and that actually ended up caused his a little bit of worsening during that short term. So just keep that in mind. And as you know, remember from your med school days that anticholinesterase inhibitors are the maintenance therapy for this condition. But keep these kind of strange, different scenarios in mind as you're seeing your sinus patients, because like I said, not everything is sinusitis. And as clinicians and as we need to keep our thinking hats on when we see folks and know that in order to treat them properly and get them on the right treatment path. So I'll here in just a moment, I'll just take any questions. Those are the 5 cases I wanted to show with you today, just to kind of highlight the fact that any one of these conditions can present with sinus symptoms, but had vastly different treatment algorithms and considerations. So I will open it up to questions and go from there. Just looking here. All right. Well, I don't see any questions. Again, I appreciate you all for tuning in. I really hope we don't have to continue these types of seminars, that we're able to go back to kind of a more normal state, but it's really incredible to see all of these clinicians together to try to continue your education, and I think this is a fantastic platform to do it. I hope you all find this useful. If you guys have any questions sort of offline, please shoot me an email. But otherwise, I just wish you all a fantastic Wednesday, and please stay well and healthy, and know that we're here for you. Thanks much.